I want to give you just a flavor of some of the things that we're doing with use of technology at St. Luke's. It's always good, I think, for you as developing professionals to see what really works in a clinical environment, and especially with patients that are very complex. And so we'll talk a little bit about what makes a patient so complex that we see at St. Luke's. I've got some slides in there that you will see in a few minutes that are explain a little bit about what St. Luke's is. I don't know, has anybody ever been to St. Luke's before? Okay, what were you there for?
I helped Kayla with one of her
Great.
TBI plans.
Okay, all right, so you're there kind of in a research capacity. Anybody ever have any family members who have been to St. Luke's? I know Diane has. Yeah, so we'll talk a little bit about how people get to St. Luke's, what happens in most cases to their nervous system that would cause them to end up in a facility like St. Luke's. And so let's jump right into it. So I guess, I was trying to figure out gerund technology. That wasn't a word that existed when I was your age. And so I was sitting there just pondering what that is and what meaning it has for a very applied environment like St. Luke's. And kind of the best I could figure out is that St. Luke's is a location where technology is translated to support patient care. And the gerontology part of it, I think, gets at the type of patient that comes to St. Luke's. You know, most of our patients are greater than 65 years of age. And so we're beginning to see that big swell of the baby boomer population that's starting to come through, and medicine advanced to the point where we keep people alive a lot longer than we used to be able to do. And so that means that they come into an environment like St. Luke's to try to overcome some type of impairment. And our goal is, as it says right here, we want to be able to get patients to regain functional independence. So the idea that a person does not have to depend on someone else for every single task that they might perform. Some of our patients fully achieve that. They get back to a life where they are so independent that even doing things outside of the home is not a challenge. Good example of that would be driving. And we have other patients that are going to have some level of dependency. They may be able to do some activities of daily living. Is that a term you're familiar with? ADLs? They may be able to do ADLs in the home, but they may need some help with more complex ADLs, or maybe even activities of daily living that they have to perform outside of the home. But the goal of St. Luke's is that we try to get people to a point where they can regain as much functional independence as they possibly are able to achieve. Most of the patients that we see at St. Luke's are there because either they have a disease that affects the nervous system, or they've had some type of injury to the nervous system. And so kind of the prevailing philosophy in rehabilitation nowadays, and certainly in terms of neurological conditions, is that we try to target the plasticity of the nervous system. So is that a term that you're familiar with, this idea of plasticity? And so 20 years ago, therapies would not focus on plasticity because it was not a well-founded idea coming out of the neurosciences that the nervous system could actually regenerate itself. And so therapies 20 years ago focused on trying to get people to compensate for impairments. And so if you had a paraplegic arm, I'm left-handed, so I always think of this as the arm that would really affect my function if I had a stroke that would affect the left side of my body. 20 years ago, the focus would not be on trying to retrain the paraplegic hand. Instead, it would be how to train the person to be able to use the functional hand and other types of devices in the environment that could help them be as functional as possible. So it was almost as if you forgot about the side that was impaired. Well, nowadays we don't do that. Nowadays, one of the primary goals is to take advantage of this plasticity of the nervous system to try to help the individual regain as much function as possible in the side that's been affected by some injury to the nervous system. Any questions on that? So let me explain a little bit about what St. Luke's is. I'm amazed at how many physicians I run into that don't work in a post-acute care setting that really have no idea how healthcare is organized outside of the acute care hospital. And so if we were to look at somebody that had an event that might cause them to be hospitalized, let's say it's a stroke, the first place that they usually end up is going to be in an acute care hospital. And so Pullman Regional is that the name of the local hospital. So that would be an example of an acute care hospital. If we move into Spokane, that would be Sacred Heart Medical Center or Holy Family Hospital, and Deaconess Medical Center, Valley Medical Center. So those would be the acute care hospitals. That is where they try to get the primary condition under control. They try to medically manage it, but the goal in acute care is to make the stay as short as possible. And so when people are discharged from acute care, then there are a range of options for where they might go for continuing care. And if their condition is severe enough that they do need to have continuing care, so in other words, most people with a stroke don't just get discharged home with no additional services. There's always some type of follow-up care. That is referred to post-acute care, and there are usually one of four spots that a person might go to receive additional services. We've got two that would basically be where the patient would be discharged to home, and in one situation they might be discharged to home, but they would have follow-up appointments that would be held in a clinic. And so they might go to a PT clinic and have a series of appointments there to help try to resolve some of the residual impairment after a stroke. If they're a little more severe, so that they're not quite ready to be in a PT clinic environment, then they might have healthcare providers actually come into the home. And so that is naturally referred to as home health services. And so this would be, these two settings, post-acute settings, would be reserved for patients that are really fairly functional on discharge from the acute care hospital. If patients need to have continuing nursing care, so they need to have somebody that's looking at their vital signs, managing their medications, making sure they stay stable. If they are discharged from the acute care hospital and they need more care, in particular 24/7 nursing care, then they will usually be discharged to one of these two settings, either a skilled nursing facility or an inpatient rehabilitation facility. And so the skilled nursing facility is going to have 24/7 nursing care, but it does not have any requirements for rehabilitation. Most people do receive some rehabilitation in a skilled nursing facility, but the Medicare does not require for them to have therapy in those settings. And so there's no guarantee that an individual that's in a skilled nursing facility is going to receive additional therapy to help try to resolve the impairment. And so that's not a setting you want to go to. If you can at all help it.
So
Yes.
are many people that are discharged to skilled nursing facilities, is that usually they're thinking it's going to be more of a long-term placement, or do they usually actually get out of those?
No, skilled nursing is still considered to be a short-term post-acute stay. It's limited by how much Medicare and Medicaid, how many days of therapy or days of care they can have there. And so the idea is that it's not going to be a long-term placement to begin with. Maybe the best distinction between a skilled nursing facility, which we call a SNF, by the way, as opposed to an inpatient rehab facility, which the people in SNFs call us IRFs. So the difference between the two is going to be that skilled nursing facilities are really where a person is trying to recuperate. So they may not quite be ready for an inpatient stay that would focus on rehab. When you get to the IRF, the inpatient rehab facility, that's where the focus is on rehabilitation. And so St. Luke's is that fourth type of setting. And it is required by Medicare and Medicaid. We have to provide 3 hours of therapy a day. And that can be any combination of therapies. If we don't provide 3 hours of therapy a day, we don't get reimbursed. And so an individual that comes into an inpatient rehab facility, when we're over at the acute care hospital trying to figure out which patients would benefit from an inpatient rehab stay, these tend to be patients that we know want to get over their impairment, and that have some function that would lead us to believe that if they receive 3 hours of therapy a day, they would gain more functional independence. And so it's really kind of a special class of patients that would qualify to come into an inpatient rehab facility. The 3 hours of therapy can be any combination of physical therapy, occupational therapy, or speech therapy. And so those are kind of the three main therapies that are in an inpatient rehab setting, although we also have recreational therapists that work with the patients. Our patients love our rec therapists because they tend to work with them on fun stuff, really fun stuff, and not really challenge them cognitively or physically as much as the other therapists do. So that's a little introduction to how care is organized and what type of facility St. Luke's is. It's a post-acute care facility. In particular, it's an inpatient rehab facility. Any questions on that? So this is a little bit on St. Luke's. We are the largest freestanding inpatient rehab facility west of the Mississippi River. And so to think that is 90 miles away in Spokane is pretty amazing. If we go in and look at the discharges from inpatient rehab facilities in the state of Washington, year in and year out, there are 20 different inpatient rehab facilities in the state of Washington. Year after year, St. Luke's is responsible for about 25% of the discharges in the state of Washington from inpatient rehab. And so definitely a large facility, regional capture. The region that St. Luke's captures from goes all the way over to the Cascades, all the way down to the northeast portion of Oregon, all the way up to the Canadian border, and then now we have a reach that's all the way over on the other side of the Rockies into Montana. So we have a very large catchment area for bringing patients in. To give you an idea about how large we are, we're licensed by the state of Washington for 102 beds. If you went through and counted the number of beds in St. Luke's, we wouldn't quite be at 102. It would actually be mid-80s because we've converted some of our rooms so that instead of having 2 hospital beds, we've taken one out so that there's a little more room in the rooms for patients that might be in large motorized wheelchairs, or something that we're seeing more of is patients that we refer to as bariatric patients. So they are so large that we have to have specialized equipment to be able to lift them in and out of bed. And so in a room like that that's set up for a bariatric patient, we need to have a little more room to make sure we can get the equipment in there to be able to help them get from lying to sitting to standing. So we actually have therapists even in the acute care setting. So over at Sacred Heart Hospital or Holy Family Hospital in Spokane, St. Luke's therapists are actually embedded in that hospital so that the rehab process actually begins in the acute care setting. We don't wait until the patient gets to St. Luke's before they begin working with the different therapists. So it's a really good environment for the patients to be able to get an assessment and begin working on therapy activities in the acute care hospital before they actually get to us. And then we go even further out in the continuum. We have therapists that are out in some of the regional rural hospitals. I don't think we have any in Pullman, but I think we do have some in Colfax, some therapists in Colfax. We also have a series of outpatient clinics, and together with both our inpatient setting and our outpatient setting, we have more than 680 healthcare professionals of various disciplines, everything from nursing all the way through physicians that work for St. Luke's. And all of that translates into 21,000 inpatient days. So that's annually how many days of care we provide to patients across a year. And in the outpatient setting, more than 72,000 visits a year. So imagine the data that's being generated on a daily basis just from the patients that we see in these environments. So who comes to St. Luke's? What types of conditions do people have that would qualify them for an inpatient rehab stay? So there's actually 19 different classifications that go everything from things that happen to the nervous system all the way down to if an individual has had an accident where they are burned severely. At St. Luke's, the three most common conditions for which somebody would end up at St. Luke's are stroke, some type of brain injury or traumatic or non-traumatic, and then spinal cord injury, either traumatic or non-traumatic. And so if you look at at some of these, I threw a little parlance in there for you, LOS. Anybody know what LOS stands for? Length of stay, yeah, sorry about that. I should have defined that for you beforehand. So if you look at the length of stay, so anybody know what the average length of stay would be in the first step in the continuum of care in the acute care hospital? You know what, in the U.S., what the average length of stay would be in an acute care hospital? Take a guess.
As little as possible.
Yeah, as little as possible. It's actually 3 days. That's the average length of stay in an acute care hospital. That's across all conditions. Really, it's a pretty wide standard deviation. But the acute care hospitals want to get the patients out of the acute care setting as soon as possible. And so we tend to have longer length of stays, mainly because of the goal to try to help patients regain functional independence. It means there needs to be some hard work that goes on across a longer period of time. And so for stroke, we had 527 patients that were stroke patients in 2016. They had a little more than a 2-week stay with us. And the average age was 70, so we're talking about a gerontology population when it comes to stroke. For brain injury, had 228 patients that would be brain injury patients. Average length of stay was 13 days and the average age was 59, so we're beginning to border. What do you consider to be the age at which somebody becomes a gerontology, they would enter into the gerontology population? What age is that? Is it 65? Okay, that makes me feel good. I cracked the big 6-0 this year, so you know it's all these weird things that go through your mind. It's called aging in place, mainly in my mind. For spinal cord injury, we had 93 patients that would fall into that particular diagnosis. Length of stay is a little bit longer, 17 days. And believe it or not, the average age is 63 for spinal cord injury. Part of that is due to there's kind of a cycle to spinal cord injuries. We see a lot in the summertime, and we see a lot in the winter. The ones in the summertime tend to be a little younger, and it's mainly with, I hate to say it, guys, but the predominant population is going to be younger males that go out and do stupid things. And so we tend to see quite a few younger males in the summertime. Then in the wintertime, we begin to see more of an older population. And a lot of times it's from slipping on ice that not only causes them to have a brain injury, but they also have involvement with the spinal cord. And so we tend to see this almost bifurcation in ages across the year. Couple of other conditions: lower extremity amputation, cardiopulmonary conditions, and then what's called major multiple trauma from things like car accidents. And so most of our patients are discharged to home, but with additional care. So they might not start. Remember the first box? Remember what that first setting was? It was over here. What setting was that?
In-home or outpatient?
Yeah, so outpatient clinic care. So most of our patients after discharge from St. Luke's still have residual impairment that we feel could benefit from additional therapy sessions, but they don't need 24/7 nursing care. And so most patients will receive care in, for example, one of our outpatient clinics, even after discharge from St. Luke's. So it's not that they're completely tuned up and ready to go at the end of the stay at St. Luke's. It's that we've gotten them to a point where we feel like they're medically stable enough that they can go home, but in most cases with continuing therapy services on an outpatient basis. Some patients are discharged from St. Luke's and then have home health come into the home. A good example of that is a patient that is on Coumadin. And you know what Coumadin is? It's what? Yeah, it's a blood thinner. So you have to have daily blood tests. Usually, actually, it should be several times a day, just to make sure that you're not over thinning or under thinning the blood. And so in a situation like that, especially if you have an elderly patient, they will have home health services that will come into the home after discharge from St. Luke's and actually perform the blood test for them a couple times a day. So at the end of an inpatient stay, there are usually additional services that patients engage in after discharge from St. Luke's. The good news about that is that if you think about it from a research perspective, if we can get them enrolled in a study while they're at St. Luke's, then it gives us an opportunity to be able to follow them even when they get into a home setting. And so it really is a nice environment for being able to engage patients long term when they're recovering.